brain metastases are quite common in patients with EGFR mutations. Historically, up until the modern era, up until the era of personalized therapy, we typically treated these individuals with whole brain radiation, then more recently with stereotactic radiation. But you can make a case in those individuals who have relatively low volume brain metastases, who do not have symptoms, who do not have much in the way of vasogenic edema, for observing their progress simply on TKIs alone. And in fact, that has been looked at. There's been a retrospective analysis by Schuler and colleagues published in JTO in 2016 that looked at overall progression-free survival both in LUX-Lung-3 and LUX-Lung-6. And the bottom line is that the PFS benefits seem to track the overall population, including those without brain metastases. In LUX-Lung-3, PFS was over 11 months for the group with brain metastasis, compared to roughly 5.3, 5.4 months for the control group. And we see a similar benefit at 8+ months versus 4.7 months in LUX-Lung-6. It's a little dicey because you are taking a population with known brain metastasis, with the potential of further growth and evolution of these brain metastases, the possibility of developing vasogenic edema and generating intracranial symptoms, headaches, nausea and vomiting, seizures, stroke-like symptoms. So these individuals need to be followed very closely. If we do not initiate brain-specific treatment, I'll generally get MRIs every 2 to 3 months at a minimum. Obviously, should there be evidence of CNS progression, then you need to intervene. And increasingly, particularly in the new millennia, in the 2018 and beyond, we are applying stereotactic radiation or gamma knife to these individuals for several reasons. Number one, the smaller lesions will often recede with the use of TKIs. Number two, gamma knife spares cognitive dysfunction. We have found that if you can use multiple converging beams selectively on individual lesions, that the risk of CNS toxicity goes down. Unfortunately, disease progression in patients with EGFR mutation is almost always inevitable. It may take 2 years, 3 years, 4 years, 5 years and beyond. And I do have some patients in my practice who've been fortunate enough to remain free of progression beyond 5 years, but by and large, the majority of patients will experience disease progression. If we look at LUX-Lung-3, which is probably most representative of the population that we deal with in North America, the PFS, median PFS exceeds 13 months. This patient has been on treatment now about 9 or 10 months, so it's conceivable that in another 3 to 4 months she may experience disease progression. Remember, that's a median. 50% have disease progression beyond the median. Sometimes it can be years out. At the time disease progression is established, at least in individuals who are receiving first-line or second-line TKIs, first generation or second generation, be it erlotinib, gefitinib, or afatinib, it's imperative to test for T790. If T790 is disclosed, and that is found in about 50 to 60% of patients with EGFR mutation who develop disease progression, then the standard of care in that group is osimertinib, which is specifically designed against T790 as well as the original EGFR mutations. 30, 40% or more will not exhibit T790 mutations. In that group, it's a bit more problematic. The standard approach remains chemotherapy as second-line treatment. In general, we will institute a platinum-based combination, often platinum and pemetrexed, or if there's no contraindication, platinum, pemetrexed, and bevacizumab, or platinum taxane and bevacizumab. And very frequently, these patients will go on to enjoy another prolonged disease-free interval, at least progression-free interval, before they face the prospect of additional or third-line treatment. That's an area that's really unexplored. There are some studies now that are looking at actually going back to a different TKI in that setting. Say a patient received erlotinib or gefitinib, trying afatinib or osimertinib, or just reinstituting the original treatment with the premise that the original clone that harbored the mutation may have expanded in that interval and that the patient may retain some sensitivity. There's one very important trial, though, that has actually tested the concept of continuing the initial TKI through chemotherapy, and that was the IMPRESS trial that was run by Tony Mock and Jean-Charles Soria, that looked at patients who had been on gefitinib, who had experienced disease progression, and compared a standard chemo combination, platinum and pemetrexed, either alone or the combination of platinum pemetrexed with continuation of gefitinib beyond progression. And intriguingly, the group that got all three agents, the TKI plus chemo, actually did worse. There was no increase in response rate. PFS was, if anything, a little bit worse. And survival was actually significantly worse. So there's a big concern that chemotherapy and TKIs, when given concurrently, may antagonize each other. And I've really taken the message from that study to heart. We'll continue give chemotherapy. I'll usually suspend the TKI just a few days before I start the chemotherapy. If the chemotherapy stops working, then I'll entertain resumption of TKI or some other protocol that would be appropriate in that individual. It's only in very selected cases that I'll continue a TKI even while I institute salvage chemotherapy.